that I'll call Dr. SURBI and she'll talk about hypotonic maculopathy. That's another, the message in that I think she will give you, because we have been dealing with a couple of these cases. So let us see what she has to. She's my fellow at Center for Sight, New Delhi.
Thank you, sir. Good afternoon, everyone. I am Dr. SURBI TANEJA. I am currently doing my fellowship in glaucoma and cataract services at Center for Sight, New Delhi, under mentorship of Dr. Harsh sir. First, I would like to thank everyone for being here, and sincere thanks to AIOS and Harsh sir for this amazing opportunity. Today, I'll be talking about hypotony maculopathy. And as glaucoma surgeons, I'm pretty sure we must have come across hypotony more than once. Hypotony can actually lead to a very dreadful complication called as maculopathy, which usually puts the surgeon in a dilemma as when and how to treat it. So let's take the discussion a little forward. Hypotony refers to the IOP less than 6.5 mm HG, but there's also something called as the clinically significant hypotony, which refers to the condition where the IOP is low enough to cause the visual loss. Hypotony can occur usually in the early post-operative period within 2 weeks, or it can occur later as well. The early hypotony, however, is mild, transient, and responds very well to the conservative measures, whereas it is the late hypotony that we need to be a little serious about. Hypotony can be caused by many factors, which I would like you to have a look at. But right now, we will be focusing more on the hypotony which occurs post-trabeculectomy. It can occur due to an overfiltering bleb, a bleb leak, or due to the underproduction of the aqueous, which could be due to ciliary body shutdown, cyclodialysis, ciliocoroidal detachment, or a retinal detachment. It has been seen that with the widespread and the increased use of MMC, the incidence of the maculopathy has increased over time. Here is a video where you can see a bleb leak. A quenching of the dye can be very clearly seen. If hypotony is not addressed, it will lead to maculopathy. The first time maculopathy was described by Della Porta in 1954, and later on the term was given by Gass. The present incidence for maculopathy is 1.3 to 18%. But do all the patients with hypotony develop maculopathy? No. There are certain risk factors: male sex, high myopia, young age, bleb leak, use of antifibrotic agents, primary filtering surgery. The antifibrotic agents, as the name suggests, they prevent fibrosis and have a tendency for overfiltration, and they can also have a direct toxic effect on the ciliary body. Usually, these patients present with low IOP, chorioretinal folds, optic nerve swelling, vascular tortuosity, or relative hyperopia. These chorioretinal folds, they appear as dark and light streaks on biomicroscopy, and the cause for them is the scleral wall collapse or shrinkage, which results in redundancy of the retina and choroid and throws it into the folds. The optic disc edema usually occurs due to the anterior bowing of the lamina cribrosa, which compresses the axons and halts the exoplasmic flow. So the low IOP alone will not determine whether a patient will develop maculopathy or not. It depends upon the biomechanical properties of sclera mainly, that is the scleral thickness or scleral rigidity. Therefore, those young patients or high myopes, they have thin sclera and low scleral rigidity, and they're more prone to develop the maculopathy. We can do the imaging techniques for to see the chorioretinal folds. FFA will help us see even the subtle folds. B-scan will show us if there is an RD or CD. UBM, we can see if there is any suprachoroidal effusion or cyclodialysis. They will help us to rule out any causes for the hypotony. OCT is a wonderful investigation, easily available in ophthalmologist clinic, which help us to see the chorioretinal folds, diagnose maculopathy, and also help us in following up these patients. So now the question of the hour: when does maculopathy develops after hypotony? Well, there is no particular time period. There are case reports where it has developed on 3rd day post the filtering surgery, as well as where it has developed 14 years after hypotony. To prevent the hypotony, intraoperatively we should maintain the chamber depth, and while suturing the scleral flap, the suture should be tied tightly. There's another thing that Dr. Harsh does in his cases, which are high myopes. We cannot use MMC, as Sunita ma'am said. So in those cases, we use anti-VEGF, and most of our patients are doing well, and none has developed maculopathy. Post-operatively, to prevent hypotony, we should gradually release the sutures or do the suture laser suturolysis. Once diagnosed, it has to be treated. Should start with the conservative management, and later on we can do the surgical therapy. It provides very good results. If there is a bleb leak, we can give echo suppressants, do pressure patching, use a BCL. There's argon laser conjunctivoplasty, which will help us in limiting the overfiltering bleb, and we can seal the leak as well. Compression sutures can be applied over the point where there is leak, and in case it's an overfiltering bleb, we can apply multiple compression sutures. Conjunctival advancement can be done. Surgical revision actually has the highest success rate, 80 to 95%. Here is a video. If we have to see the health of the conjunctiva. If the conjunctiva is bad, then we can remove that conjunctiva and advance a healthy one, or we can use a conjunctival autograft. Then we have to look at the scleral flap. If it's overfiltering, then we can add 1 or 2 sutures. And if there's a leak or if there is a dehiscence of sclera, then we can use a scleral patch graft over it and then do the conjunctival closure. This is a OCT of a patient who developed maculopathy, and he refused treatment, so it became chronic for 6 months. And then we operated this patient, and as below you can see, there's the post-surgical management OCT. The foveal contour was restored and folds resolved. We did the bleb repair in this case of the chronic maculopathy. So now we know that maculopathy can develop anytime after hypotony, and also how to treat it. So, but now the question remains that when should I intervene? If you see hypotonies there, definitely as soon as possible, and so is the case with maculopathy. What we basically don't want is that the chorioretinal folds should not coalesce with each other. That is, they should not become permanent and there should not be any scarring. Till then, we should always give a treatment trial to the patient. Surgical bleb revision is a very good method, has high success rate, and it gives a very good visual recovery. So the crust of this talk I would like to tell is that the conservative measures, they work best for the early cases. And in those cases where the conservative measures are not working, the resistant cases, or where the maculopathy developed late or it has become chronic, in those cases we can do bleb revision as a primary management. It helps in visual recovery, as well as it's very good for the patient because it will help in raising the pressures. Thank you everyone for listening. Thank you for being here.
Thank you, Surbi. I think that was wonderfully done. The crux of the matter, as she rightly said, was that I was also sometimes scared, bhai itna din ho gaye hypotony ke, and the hypotony has been lasting for now almost a year, and they are folds. But get an OCT done. If the folds are not attaching to each other, you know, if they are attaching, then you'll need an ERM peeling and all those things will be required. If they are not attaching to each other, just a simple bleb revision will give you wonderful, wonderful results. So that is the message. Yeah, please.